Hello, all. Welcome. Welcome to another episode of Direct Shift Stories. And in this episode, we are connecting clinicians directly to employers using AI technology at Direct Shift. So I'm your host, Rajmisa, and today we are joined by our CEO, Vamshi. He's also going to interview Dr. Kyle Hoedebecke on the future of family medicine and what doctors wish patients knew about. So we'll discuss the ins and outs of family medicine, and be sure to listen all the way through the end of this particular show for the surprising details. Over to you, Vamshi. Thank you.
Thank you, Raj. Dr. Hoedebecke, again, privileged to have you on our platform. I'll be thanking you multiple times today. In fact, I feel we are a tad little bit late in getting Dr. Hoedebecke onto the platform after knowing your deep expertise and vast experience across multiple areas. I just feel this relationship is definitely 2 years late, but I'm nevertheless so glad to have you on our platform. For all you our audience out there who are listening to us live and who are going to see the recording of this podcast, as you all know, we are bringing stories of clinical leaders, clinicians, executives, tech leaders on our platform, predominantly to kind of share the message of trends of where the practice of medicine is headed, may it be physical health, mental health, or outpatient care, inpatient care, telehealth care. We're trying to bring those stories forward. And today we're joined by Dr. Hoedebecke, who actually needs no introduction, but I'll try my best to introduce him in the next 30 seconds. And I will also hand it over to Dr. Hoedebecke to give us a little bit of a background about himself. Is a board-certified family medicine, is a great physician executive, has held multiple roles as a physician executive. In addition to that, is also the fellow of the AFP, senator of the WBAF, 70 plus medical publications across 5 continents in 8 languages. Research, executive roles, practicing physician, plus he's also an angel investor and a heavy enthusiast in the health tech space. So without further ado, I really want to introduce to you all Dr. Hoedebecke here. And it's our privilege to have a physician executive and a tech enthusiast and entrepreneur and investor like him on our platform today. I am going to thoroughly enjoy the next 15 minutes or so. I just told Dr. Hoedebecke this could go on for the entire day, but we'll try to keep it within an hour out of respect for his time. And thank you for making time on Saturday. This is going to be hugely helpful for our audience, wide network of clinicians, as well as health systems and healthcare organizations out there. So Dr. Hoedebecke, thank you for your time again, and please, take the next 30 seconds to 1 minute or 2 minutes. Give us a brief background of your journey. You are an innovator. You are a physician executive, practicing clinicians. You are, I couldn't count on my fingers. How did you get here? What is the biggest motivation in your life, and what is your story?
Thank you again for inviting me to be here. Super excited and happy to share my time with you and everyone watching. But yeah, a little bit about my background. So I started off just purely through the military. I went to the U.S. Military Academy at West Point, then went on to the Uniformed Services University, which is the only active duty medical school in the United States. So they call it the West Point, or the Military Academy equivalent of medicine. And that's located in Bethesda, Maryland, the exact same location on the exact same campus where President Trump, when he was admitted, that's where I learned medicine. So the president, vice president, senators, House of Representatives all get their care there. From there, went on to my residency in family medicine and did that in North Carolina. I stayed, and that was out of Fort Bragg, North Carolina. So that's the biggest military base by population in the world. So very busy, lots of hands-on, great experience. wonderful learning environment. Stayed on with the 82nd Airborne, which is a very famous military unit. Had four more jumps into World War II to help us defeat the Nazis. Very glorious background. Was fortunate enough to get embedded as a physician within the unit, where I was both treating patients, jumping out of planes, jumping out of helicopters, and helping our commander make decisions on the medical front. After that, took over 4 different clinics. They're Army clinics, but they were in Korea, so South Korea specifically. So I finished up my time there in South Korea. In 2019, when I got out, transitioned a little bit from purely clinical and administrative clinical medicine, and have switched into telemedicine. And the majority of my time now is with a tech company that's also in the health insurance space called Oscar Health. Started up in 2012 and now is about $4.3 billion valuation. So I serve as a medical director there. During the day, in the afternoons and evenings, I switch hats and I turn into a angel investor and advisor for startups. And my specialty is anywhere in the 3D printing, AI, virtual or augmented reality, wearables, SaaS platforms, as well as biopharma. So really in that space is where I excel.
Wow, thank you so much, Dr. Hoedebecke. Quickly, first of all, thank you for your service. It's great to have somebody who served, and you are a double hero. Frankly, if the pandemic has taught us that all of our frontline workers or healthcare workers and healthcare executives are heroes. You served in the Army, you're also a healthcare executive, you're a tech entrepreneur, you are a double hero. Thank you so much for your service. So you did, one thing that caught my attention quickly was in 2008, you started shifts towards telemedicine. That is probably, you're probably one of the first innovators in this space. Now everybody's talking about telemedicine, but 13 years ago, you started to talk about telemedicine and you switched from, the physical practice of medicine and started to see the need for telemedicine. Tell our audience a little bit on what spurred that kind of a need and that kind of an interest in tech-enabled medicine.
That's a great question. And basically around that time was when we really started to improve our connectivity online. We were starting to have smartphones, everyone was connected, and it just kind of clicked at that time. So we did start slowly, but surely working more on the academic side, and then got into the clinical side of medicine on that front. I saw that as our future. I even after my MD and my board certification, went on to get a master's degree in telemedicine and e-health. And at the time, there were only 2 locations in the world that even had such a program. I believe one was in Norway, one of the Scandinavian countries, I believe Norway, and then the other one was in Rome, Italy. So I actually completed a master's in telemedicine e-health. Fortuitously completed that about a year before COVID hit. And not that I'm glad COVID hit, but it gave me the right skills to really shine in that environment and get people on the right track. So I just saw at that time that this is where we were heading, and eventually we got there. COVID really pushed us over the hill a little bit farther, huh?
Yep, exactly. I think that's well said. I think COVID accelerated what would have otherwise been a slow-moving evolution, but it did accelerate. And we see the same thing in our day-to-day work. As you all know and our audience knows, we connect clinicians directly to employers, physicians, nurse practitioners, all the providers, plus nurses, in order to Uberize, pretty much so as to call it, the healthcare recruitment and staffing. And we are actually seeing a lot of requests for virtual care in various parts of the country. Having said that, one of the big trends that we're also observing is clinicians are now more ready to do telemedicine for sure, but there is still that propensity, that tendency to be more comfortable with the in-person care. Of course, clinicians want to kind of see the patients in person as much as possible. Plus, COVID has its own restrictions. But we are seeing the clinicians are having to wear two hats, to be ready for the actual physical practice of medicine, but also to be ready for, let's say, in their available time, to be ready to take up tele practices, etc. What do you recommend to such physicians? How do they make that shift? It's not easy for everybody to quickly make a tech shift. What is required for physicians, especially for them to do in order to imbibe and adopt the tele technologies more, and potentially continue to wear both the hats, because probably patients require physicians now to wear both the hats?
Sure. So telemedicine, in my opinion, will never and should never replace in-person visits 100%. For various reasons that will take longer than an hour to discuss. Mm-hmm. But in between these necessary in-person visits, telemedicine really allows us to fortify or to augment the care we're already doing. So, for example, a patient that's admitted to the hospital for heart failure, we'll say, as an example, goes home. Telemedicine will allow us to check in on that person and have an additional medical touch and evaluation. Hey, how you doing? How's your weight? How's your breathing, et and gives you an opportunity to evaluate that patient and prevent another ER visit, a bounce back to the inpatient floor, things like that. So it really decreases the cost of medicine on a personal as well as population level. And then I'd say, even if in a different setting, a private practice setting, orthopedic surgeon, so does a knee surgery, instead of necessarily needing to see that patient in person, you could really probably do it, unless there's some sort of complication, from a telemedicine visit. Yeah, let's take a look, let's check your range of motion, and then you've really saved that person time. Right now, COVID exposure, and then the physician, him or herself, can now pop through more patients while still giving them the necessary amount of time, but increasing their bottom line, making sure that their business is staying productive in the green.
No, that's a great point. It's a great point. I think you're essentially saying there's a lot of follow-up visits that have previously been in-person visits. Sometimes because of them being in person, and it's not always easy for patients to show up. Sometimes the adherence to the follow-up visits have always fluctuated. You never had really optimal adherence, especially when you talk seniors, etc. They cannot always show up easily to the clinic. So you brought up a good point, which is there's a lot of follow-up that could potentially be converted to tele. And I'm assuming that would probably increase the adherence to medication, post-discharge protocols, and all of those things. Is that method going to help with better outcomes, making sure that each of these direct care providers are deliberately converting follow-ups to tele, aimed at improving that particular patient's outcomes?
Without a doubt, yes. I'll give you two main reasons. So one, if you convert those lower risk, lower acuity patient encounters to telemedicine, you also open up in-person rather, encounters for the more sick and the more severe cases, right? So you're able to really get the hands-on and see those more severe cases while still maintaining a high quality via telemedicine for the lower risk cases. So again, at a population as well as individual level, that's positive. And then the other aspect is because there's just a certain amount of time we can work in a day, telemedicine really enables us to see patients faster and quicker. Just a lot less moving parts. So the process of that patient visit is a lot shorter and sweeter for both the patient and the physician.
Got it. No, that makes a lot of sense. Given this, Dr. Hoedebecke, during COVID, we saw percentage of actual outpatient visits that were tele versus in person spike up. I mean, to some cases, even like 80%, north of 80, 90%, and then suddenly probably stabilized now. There are a lot of projections around this, right? I mean, countrywide and statewide, a lot of projections around, a lot of researchers saying it will stabilize around 30-40%. Some think it's probably between 17 to 25%. But I think, especially from a healthcare employer's perspective, all the clinics, practices, physician groups, hospitals, health systems, it is important that they know where that projection is landing, right? Because then they have to appropriately staff to that, create the right infrastructure and things like that. What do you think? Have you conducted any researches on your own, or have you studied the trends? Or what do you think where this projection is going to land? What percentage of outpatient visits potentially could go to tele? Again, there is no right or wrong answer. I totally understand that. But I think, how should practices plan with respect to this ever-moving projection as a target?
Sure. So as you mentioned, it will be different for each location, each practice, each specialty. But as a generalization, it's going to be down from the height of COVID, but it will be higher than pre-COVID numbers. People are now, both people, patient-wise, as well as the providers, have been exposed to this and say, wait a second, this is actually easier than a lot of inpatient or in-person visits. And now that we're able to charge at a same or similar rate as an in-person visit, which previously was a big issue, the reimbursement rates. Now the reimbursement is catching up to technology. It's really going to leave us in a better spot here, where technology and e-visits, telemedicine visits, are at a higher rate than pre-COVID.
Got it. That's a great point. I've always wondered, Dr. Hoedebecke, I don't know if this will ever be a consideration, but there's always a facility charge and a professional services charge. Will there ever be more like an infrastructure charge for tele and a services charge? Do you think this is headed that way?
I wish I could see the future on that, but as this becomes more integrated into the standard of care and everyday medicine, it's going to be adequately reimbursed, and those rates are going to be similar, in my opinion, to what we're doing in person. Because again, if the quality is the same or similar, then the reimbursement likewise should be same or similar.
Got it. Absolutely, well said. In terms of you're a medical director, at Oscar Health. You just mentioned reached 4.3 billion valuation. First of all, congratulations on that. I'm sure a lot of that had to do with your contribution as well. Tell us a little bit about what Oscar Health does, Dr. Hoedebecke, and how in your medical directorship role, how you are impacting some of the outcomes.
Sure. So Oscar Health, again, is we call ourselves both a health tech company as well as a health insurance company. And we really separate ourselves from the rest of the pack with two main advantages. First, we have a concierge service. So I can tell you, as a physician coming out of the military side where everything was covered, into the civilian side where now I have to do insurance and see who's in network, out of network, what medications are on formulary or not. As a doctor, it's pretty hard. So I can only imagine what someone without a medical degree and 4 master's degrees, how confusing it is for them to get through the system. So Oscar has a concierge team that will guide each member, so each of our patients, through their healthcare journey. And this is just a godsend because it is so difficult. The second advantage is that even before COVID, each of our members gets free, unlimited telemedicine services. So again, all the advantages that come along with that, and no cost beyond the premiums, obviously, for the members. So those are the two main differences. My role specifically is on the utilization management and credentialing and quality side. So what does that mean? So utilization management portion is reviewing requests, either imaging like X-rays, MRIs, CTs, surgeries. So you can think of knee replacements, hip replacements, back surgeries, gallbladder removals, appendectomies, you name it, as well as medications. So any medications for lupus or cancer medications, things like that. We review, make sure that they are meeting a quality of care and they have evidence behind them before we approve. That's the smaller part of what I do. And then I really work with those physicians within our network to make sure that new physicians requesting to enter our network are high quality providers. So looking at their history, looking at their outcomes, things like that. And then also our internal regulations and guidelines, making sure that they're in line with the most up-to-date medicine.
Got it. Great, thanks for sharing that. And you did mention utilization management, and let me just make a correlation there and
Sure.
See if I'm aligned with you, Dr. Hoedebecke. So I think utilization management is directly tied to how best of a primary care do the patients receive. Right? The more preventative primary care they receive, the lesser there will be the need to utilize, more deeper, more expensive, more acute care. Right? So primary care medicine, family medicine is playing a huge role in being able to kind of help keep the utilization low. And if I'm utilizing lesser of healthcare services, that means I'm healthy. Automatically that means it's good for the entire population.
Mm-hmm.
So with that correlation, assuming that is correct, what is primary care really getting better and better in helping keep the utilization levels lower, especially with telehealth now coming in? Are you seeing primary care really getting better and better? Because we still, in our work, we still see there are areas for improvement. I would love to brainstorm those with you, but what are you seeing in terms of the primary care space?
So there's two aspects to that. It's the quality of the primary care, as you mentioned, getting better and better, but actually just using primary care in the first place and not saying, oh, I have knee pain, I'm going to go straight to the orthopedic surgeon, when the family physician can probably take care of 80% or more of those complaints. So it's making sure that the population, one, is engaging with their primary care physician. So I could have a primary care physician, if I don't see him or her, it's not helping me, right? To make sure that I'm healthy, and then not skipping that primary care physician as well, and going straight to a dermatologist, a orthopod, whatever it may be. If you need a surgery or some sort of special high-level specialty care, sure, by all means. But again, primary care can take care of approximately 80% of any specialty, which is why Oscar Health really loves primary care physicians, because we have experience from I deliver babies, do prenatal care, all the way up to hospice and end-of-life care, seen it all and familiar with it all. And then if it's something beyond what we are comfortable or trained to do, sure, we'll get that next level of care involved. But again, that's usually at a higher price point. No,
absolutely. That's well said. I think family medicine has the whole spectrum, cover the whole spectrum, and making sure you are utilizing your primary care in the right way and spreading that awareness across patient population is important. So in our work, we are seeing a lot of underserved areas, rural areas. Urban health systems, frankly, do not have that much of a trouble attracting talent. They probably need more help in understanding what is the exact need versus who is the right match and who is the right quality physicians, like you mentioned. But there is still a lot of areas in our work that we see that have access issues. They don't have enough physicians. Not many people really want to go work there. We're constantly talking to them. Are you converting enough of your population visits to tele and things like that? So in those areas, especially to provide more access to rural health and underserved areas, for them to have this awareness and access to primary care, what are some of your recommendations? What should both physicians, health executives, and potentially policymakers, what else could we be doing in order to improve that access to those areas?
Very good. And this is not just an issue here in the U.S. It's an issue in a lot of countries around the world and, that have had experience and seen that as well. But I think, again, going back to telemedicine, it really removes a lot of those physical barriers to see a provider. One of the ways we're getting around our physician shortage is through mid-level or advanced practice providers, so PAs and nurse practitioners as well. So those are helping fill that gap as well. Some other trends I've seen are using community healthcare workers. So these are people who have maybe some basic medical background. They're not, again, they may be a paramedic or somewhere along that line where they understand and can help, one, engage, but also to give advice to their local community. So I've seen that become more of a trend. I did a short fellowship in Cuba, and their entire practice in healthcare systems, their foundation, their bedrock is family medicine. Every single provider, every single physician there has to be family medicine first before they specialize. It's pretty interesting. So they have a really awesome system where there's this communication is based on a relationship, and that's a big part of medicine. I think we've missed or gotten away from here in the U.S. So I'd like to see a little bit more of that as well.
Well, that's a great point, Dr. Hoedebecke. I think there are some of these subtle good policies and practices in other parts of the world that we could pretty much imbibe and we could pretty much adopt. The other day we had a clinical psychologist, physician on our platform, and he mentioned that I think in Argentina, almost majority of the population has a therapist. It's more like you having a teacher, and there's no stigma attached with it. In fact, they talk about it saying, "Oh, my therapist is better than your therapist." And I was surprised that there are such practices, and policies that exist out there. And like you just said, in the primary care relationship in Cuba. So you have traveled the world. I mean, you have publications across multiple languages, across multiple continents. Particular to primary care and family medicine, and getting better health outcomes, is there an easy place for policymakers to understand, or healthcare executives to understand, what are some of those learnings from these other parts of the world that they could potentially be using in our health system?
So a big initial fix, or area of focus, I should say, is the system itself, the process of healthcare. So if you look at the graphs of how healthcare has been, costs specifically have been climbing decade after decade after decade, and you compare the cost of physicians' salaries and other medically related expenditures, they go up, but very slowly, whereas the cost of healthcare goes up exponentially almost. So that difference there is administrative costs, different amounts of overhead, and those areas are really areas we can look at to become more lean and decrease costs, in my opinion. So I think that the medicine we practice, the options we have for care are second to none worldwide, but at the same time, our outcomes are not at the same level. So why are we spending so much, have such amazing medicine, but our outcomes they're not even the same as a country like Cuba that spends 2% of what we do. So it doesn't make sense to me.
Totally. I think that's well said. I think it'll be an interesting graph to watch, and just put in front of all of the key decision makers in healthcare. One of the things that we have observed, Dr. Hoedebecke, is there is always this big discussion going on with respect to using advanced practice providers. We do in our current work, we are always agnostic to. Sorry, just give me a minute.
Nope, you okay?
My water bottle is a little bit away from me. Give me a minute.
Yeah, go get the water bottle, no problem.
No, probably now we need the telemedicine opportunity for primary care. Probably now live consultations.
I'll send the bill in the mail.
I'm in safe hands. For all the audience, don't worry. I have a physician with me. So. Thank you. Sorry for the disruption there, but thank you. So, what I was saying was, there's a lot of the comfort level with using advanced practice providers is growing. We see that in our work as well. There's a lot of employers, healthcare organizations that are asking us to build a pool of advanced practice providers for them as well. We see that increasing, and our perception and understanding always has been with more advanced practice providers coming into the mix of providing healthcare, some of the access issues could potentially be resolved, things like that. But the quality of care issue has always been pretty much a stickler. So, advanced practice providers may not be able to do everything that a physician does, but should there be, as healthcare employers shift more towards this optimal skill mix, let's say, the right number of physicians to advanced practice providers, how do they continue to ensure that the quality of care standards continue to remain, and wherever there is physician supervision needed or wherever outcomes are needed, they're still maintained. By no means I am suggesting that quality of care is lower when there is in advanced practice providers. I'm just referring to a discussion that continuously happens out there, which is, as you move your skill mix more towards advanced practice providers, there is a perception that you're doing it for the cost purposes, but you're not considering the quality aspect of it. So how do employers really have to tackle with that discussion?
Yeah, so I think it's 2 points. There's the cost aspect where, a physician, due to training background and just the years to get there, more than a PA or a nurse practitioner, the cost aspect. But at the same time, there's the need as well. There's just simply not enough physicians out there, no matter what specialty, primary care or any other specialty. So it's either we have a gap, or we take advantage and utilize these advanced practice providers to help make us healthier. So I think we've gone towards the latter there. Quality, and then again, each person's different. I've had PAs I've worked with that were more skilled than physicians I've worked with. So it's I'd say person dependent in that regard. And then quality, that's really where the training, that the credentialing, the qualifications that you have to meet, you get tested. If you pass the test, then you meet a set standard of quality. So those are taken into account. And I'd say I'd say if this is the scope of an advanced practice provider, a physician, primary care physician may be bigger like that. Got it. I have more skills. I have more training. That makes sense. But as long as the advanced practice provider is practicing within his or her skill set, I'd feel very comfortable for them to see myself or my family.
That's a great point. And thanks for personalizing it. I think it's for all of our audience to take notice. I think that discussion is important, but I think there are ways to tackle it. There are methods to kind of put this skill mix into practice. And somebody once told me, quantity is not subjective, but quality is subjective. Quality could evolve, but the fact that we have about, I don't remember the exact number, like say 120,000 or 200,000 potential physicians shortage, in the next 5-10 years, that's non-subjective. It is there, it exists. So whatever means through which you can reduce that shortage and improve the access, is still a great solution, while the discussion of quality, which is a subjective and continues to evolve, and you can put controls. And that's I think a great takeaway for a lot of our audience out there, because what we see today is as employers request for staff, there is that constant challenge. Should we continuously try to chase filling this with physicians and then keep closing clinics where we are not able to find the physicians, or potentially not able to provide the amount of care that is being requested, or should we continuously bring others on board? It's a discussion that we always participate in, with a lot of our employers. So thank you for those insights. Coming to, that graph is still stuck in mind. You said the cost is exponential, the rates and salaries are not. So and we see a lot of salary data and a lot of rate data within our organization. And our approach has always been reduce the middlemen, reduce the administrative process, create savings from it, and distribute those savings to clinicians as well as employers. Don't price gouge, tech enable all this process so that physicians and clinicians earn more and employers also can save costs. But are you seeing enough? Just take the family medicine practice. Has family medicine practice seen enough attractive incentives from a salary perspective or incentive models perspective? Are you seeing enough attractive incentives for family medicine physicians for them to continue to stick with the profession?
So from the initial aspect, I'd say yes. So once a family physician finishes residency, there tends to be in pretty much every state ways for him or her to practice medicine in either underserved areas or in federally qualified health centers, where they can either totally erase their debt if they have any, or at least a significant portion of that. So there's that incentive off the bat, and it really helps, again, target those communities that really need primary care. Beyond that, it's different for each primary care physician. There is the ability to do fellowships, so you're still a family physician, but you kind of hone in a little bit, or at least specialize in something. So some will specialize in, like, they'll want more OB, so they'll get OB fellowship trained, where they do C-sections and a lot more OB care. Others will do sports medicine, where they'll kind of focus on that geriatrics, inpatient medicine specialties as well. So, and then I've also heard of some of my friends are actually getting into other fellowships that were traditionally for other specialties. So like a GI fellowship, which for gastroenterology, do colonoscopies, things like that. Traditionally internal medicine, but I've had some friends go that direction as well. So again, that's kind of one of the cool little incentives to be a family medicine, is you have so much exposure to everything that as things start to open up, you have more options, more doors to walk through, if you will.
No, that's a great point. I think that exposure point is really, really great. They have so much exposure. They are the first touch point. They can affect outcomes in multiple ways. And as we see, there's a lot of even payment evolution that has been happening as well. There's a lot of care evolution, bundled care, and then value-based care, a lot of that. And we are seeing a lot of family medicine practicing physicians, primary care physicians being now part of the value-based care. In fact, some employers are asking us to provide physicians that previously have had value-based care experience. So tell us a little bit about this trend.
And have you also seen, I don't know if you're seeing the trend with the direct primary care as well. That's another trend over the last at least half decade, 4 or 5 years or so. But yeah, direct primary care is also another trend. Like, as I mentioned, me working for an insurance company as well, I understand the hassle of insurance. So direct primary care physicians are saying, let's just get rid of the whole insurance piece, and I'll work with my patients one-on-one, and then they get paid directly from their patients. Again, there are different models, but in general, it's kind of a certain amount. So based on if you're doing quality, the healthier you keep that patient, the less care they need. Actually, the more money you make at that point as a physician. So again, there's an incentive to keep your patients healthier at that point, rather than a fee for service, where if I keep seeing them, I get paid more, but then that means I'm not making them better.
No, that's a great point. It's a great point. In all of these different models that are shaping up and information flooding that is happening, Dr. Hoedebecke, what should the patients as consumers be doing to be more knowledgeable? It's not easy nowadays to make a choice, right? Previously, it was not easy to make a choice because there was little information. Now it's not easy to make a choice because there is a lot of information. And frankly, I sometimes think if there is a company that explains benefits in an easier way, it'll be $1 billion company. It's like benefits have become so complicated to understand. then, oh, this physician is participating in this, so you might want to see this. In general, in network, out of network is itself a foreign concept for a lot of people. So, and now telemedicine is being included as another piece of information. You want to go to tele. What are some of how should the patient be more aware of, this evolving landscape to choose the right care?
I wish there was one single answer. So a couple of just general recommendations. Make sure that when you are looking at doing your research, it's from a reputable source. So something that is well regarded. It is, if you can, peer reviewed, or at least there's it's not a fringe source. If you're following people on social media, make sure they're also well educated. So your family physician, for me, my academic or professional associations are like the AAFP, American Academy of Family Physicians, the AMA, American Medical Association. Things like that are really great sources of information. CDC as well. So I would say follow those types of things. From the insurance side, that can be difficult. Oscar, luckily, we again have the concierge service. So you have any questions, and if someone wants to be an Oscar member, or they are, pick up the phone, call the concierge service. We always have someone available to help you out, walk you through any questions you have.
Got it. And then from a physician perspective, do they have to do anything, or do you recruit physicians to become a part of the Oscar network, or the physicians are approaching you?
Both. Both.
Okay.
So we can. So as Oscar's been growing, started out in New York City, but it's really gone across the country. I believe we're in about 45 markets right now. But we do deals with healthcare companies, so their providers would be part of that. We also do deals like on one-on-one or with groups that are in each location as well. Some people they're hearing about Oscar and the benefits, so they'll approach us, and then they just basically apply at that point. And then on the other hand, as we approach or need a network in new locations, or we want to expand our network, we have that team that will engage the local networks and see if we can get them in our network and go from there.
Perfect. I mean, I truly think a lot of insurance companies are either following or going to follow in the footsteps of Oscar, becoming more health tech and becoming more outcomes oriented versus, just providing insurance, which is two different things actually. So thank you for sharing that information.
My pleasure.
Changing topics a little, because I'm trying to cover
Sure.
many areas that you're involved in. So health tech space,
Right.
you're a part of, or a big influencer in the Angel Forum. You're an investor yourself. You're an innovator yourself, and you're heavy enthusiast in the health tech space. Tell us a little bit about, and I think, if I am not wrong, is it the Alpha Group that you have constituted as a part of engaging with health techs?
So the Alpha Group it's a peer-to-peer executive group that started in the UK, kind of went across Europe, Middle East, and just got here into the US in the last couple of years. But yeah, it's really my way to use my business background in both the health tech space and beyond, really. But we'll bring in up to 20 executives in a local environment. None of them in the same sector. So I don't want two yoga therapists in there, for example, because one, they're competition if they're here in the Dallas-Fort Worth area, and then two, it kind of limits the different perspectives we get. But yeah, it's a way that I'm working with executives in my community to really improve their businesses and then bring everybody up together. And we are in that. We do have some health tech space there. If I can name drop, our last meeting had the co-founder of Teladoc. So Teladoc's the biggest telemedicine platform in the world. So the co-founder was there as a part of our meeting, Mike Gorton, great guy. And so yeah, there's lots of ways to improve that area and take advantage and take it to the next level.
Perfect. And that I'm assuming that interactions is helping that local business owners or executives have key takeaways and potentially improve their network, to help with their business outcomes, etc. Is that the objective?
Yeah, so it's networking is definitely one. Additionally, with each meeting we'll do a workbook focusing on a specific aspect of a startup or small or medium-sized business to, again, see where they're currently at, what potential pieces are missing, and then how they can improve that, tweak that aspect to improve the value of their company. So we promise to improve the value of companies by at least 2 times, so at least double the value. And we haven't failed in 9 years. I've just joined in the last 6 months, so I can say at least my companies are in the right route, but over the last 10 years, Alpha Group has not failed on that promise.
That's great. It's good to know. I think for all of our audience out there who are business owners or potentially physician innovators or other things, I think it's something to note. I think it's a great initiative, especially when events like pandemic happens, or even in general the market is moving in a very volatile fashion and stuff like that. I think the work that Alpha Group is doing in order to enable startups and SMBs so that they can flourish, I would say it's a great cause. Thank you for that.
Thank you so much. And then the other aspect is the advising and angel network work that I do as well, and that's just a onesies and twosies. But as I've gotten more and more involved there, then just people come out of the woodwork and ask for help. So it's really trying to find those diamonds in the rough. But there are some amazing groups out there. I'm not sure if you want to discuss that or not, but I'm happy to take this conversation wherever you want.
No, absolutely. Please tell us a little more about those groups. We are all about, we are a startup ourselves. We're all about spreading information about how startups could flourish, especially in the health tech space. Absolutely. Please tell us more about that.
Gotcha. So, I mean, obviously this world in the news, everything's dominated by COVID. So I'll go ahead and start there. But if you, I don't know if you're able to look this up, but Covimro, COVIMRO, Covimro. It's a startup that has found a way to attack COVID-19 as well as other viruses in a different way than our vaccines and other treatments. So the vaccines, if you think of the ball, and then it has the spikes that come out, right? Exactly like those little red spikes. So the vaccine and everything really recognizes those spikes, and those are the areas that tend to be targeted. And we're hearing about these mutations, right? You have the Brazilian variant, the UK variant, the South African variant. Red spikes are changing. And that's going to have an effect. We don't know to what extent yet. It's going to have an effect on how effective the vaccine is. However, what if we didn't go over after those spikes? You went after the ball itself, the part that doesn't change, that envelope, and you take a piece of that ball out. It makes the virus, not just COVID-19, HIV, flu, SARS, Ebola. It makes those inactive as well as not able to be contagious anymore. So we're working on this, one, to build on the current vaccine research that's already out there, but two, there's a big like it or not, there's a big anti-vax movement for this vaccine, probably more than anything I've ever seen before. And I can understand those fears. It was really fast, and there's so many different vaccines out there. Which one's the best? When should we get it? How can I get it? Things like that, and just questions surrounding that. So this is another option for those people who are kind of vaccine adverse, and a way to help protect themselves in a very safe manner. So this is something that's going to be really big, I think.
How do you or what has been your recommendation to some of these companies that are coming up, especially more health tech companies? You're an investor yourself. and you have seen the health tech space change over the many years, and now you're advising a lot of those companies. What are some of the key recommendations and observations to those companies? What should they be really acutely aware of in order to flourish?
Great question. So in general, what problem are you solving? There needs to be, you need to either be solving it better, quicker, faster, cheaper, more efficiently. So that's the main thing. I don't want just another way to open a wine bottle. I want it to be faster, cheaper, whatever, so I can get my wine, right? or put that into medical context. But so that's one thing. Second, again, as an investor, I'm looking, well, how can I protect myself from the downside? So you have the potential upside, but you also have the potential downside. It's a risky business, risky being an angel investor. So I'm looking at ways to, one, protect any sort of data or special way that they're solving the problem. So can it be copied? Can it, one, how do we keep it from being copied? Can we patent it, trademark it, whatever it may be? And then also, should the company go belly up, is there a way that we can take that information, that IP, those patents, and then sell those and then recoup some of our costs? So I'm making a educated guess there on the way forward. So potential ups, potential downs, and also looking at timeline and the amount of money needed. Healthcare in general generally takes a little bit longer, just because of all the regulations around it. But there are ways to, especially now with COVID and the emergency acts that are available, to kind of speed in that process a little bit.
No, it's a great point. I think what problem you're solving, are you ensuring that you're solving it quicker, faster, cheaper? What is the upside and what is the downside, and all those things are great points. Thanks for sharing those. And again, being a founder myself and worked for startups a few times now, one of the things that also sometimes pricks me is, especially with now in the last 12, 14 months, all of the tech players, potential tech companies or potential tech enthusiasts coming in and suggesting, yeah, we'll solve the problem, but not really coupling it with the actual clinical knowledge, actual operations knowledge. I mean, for the last 10 years, almost every week or every other week, I have been in a hospital, consulted with hospitals for the past 10, 12 years. And more than me, a lot of the hospital operators know what the challenges are. So we have always tried our best to make sure that we are informing all of our tech developments, all of our solution developments with the right clinical knowledge and the right clinical advisors. Sometimes I do not see that happening today. Do you see? I personally see that as a big risk to any company that is trying to flourish especially in the healthcare space. Are you seeing the same thing?
Yeah. So, and let's hit the question specifically, and then I'll give you an example of a really blatant and glaring case when that didn't happen. You have the tech and medical come together. But yeah, in our space, there's the need to make sure that you're having experts from everything that's related to your company there. So you might have heard the saying, like, bet on the jockey, not the horse. That also can be taken into the angel world as well. So you might have the best solution, but if you don't have the jockey, if you have the best racehorse, but you don't have the jockey to ride and win that Triple Crown, it doesn't matter, right? So you need to have a really good leadership board. And then some people will say, well, that kind of limits who can. You have to get the experience somehow. You have to be able to have your first win somehow. So if you are, a first-time founder or second-time founder, whatever it may be, or you haven't had, multiple exits, surround yourself with people who just have that team who can really support you and show that you do have the right team to take this across the end zone and get that score.
No, great point. Absolutely. Surrounding yourself with the right people. It's like, talking to the right people is worth reading 10 books sometimes. I truly feel that, and this past 1 hour has been one such for me. So thank you for that.
You don't know what you don't know, right?
Exactly. Yeah.
Perfect example, which I said I was going to mention, is the EMR for the Department of Defense is called ALTA, and I wasn't there when it was created, but you could tell there was not enough physician input because the EMR is so bad that it's one of the top 3 reasons that physicians leave the military. So if your EMR is that bad that it's causing that many physicians to leave the military, it's saying something.
Wow, that's a great example. Great example. Thank you. Last question. Again, we'll be respectful of your time. So, last question. Dr. Hoedebecke, you're the medical director. You're in charge of outcomes at your current company, and then in the afternoon, evenings, you're advising. You're a healthcare investor. You're an entrepreneur yourself. You're a physician executive, and you follow research and articulate it in a way that people can understand and follow the research. There's multiple things that you're doing. What keeps you going, and how do you manage your time and energy to be able to do so many things at a time without being burnt out?
That is also a great question. So part of the reasons I got out of 100% clinical medicine was because I did get burned out. So transitioning from to my current roles, which are mostly non-clinical, admittedly, I still do some telemedicine, but mostly non-clinical. I find that being able to change topics and do different things, kind of like family medicine, each patient's going to be a little bit different, keeps me on my toes and really keeps me energized. And then I just have luckily I have a strong family that supports me and really supports these goals and lets me make a difference in the world. So I'm really thankful that they let me do this.
Yep. Dr. Hoedebecke, thank you so much. Make a difference in the world is a perfect way of putting a pause to our episode here. I'm not deliberately saying not a stop because I can totally see us requesting Dr. Hoedebecke to come back. But the past 1 hour, I've thoroughly enjoyed. I hope all of our audience have enjoyed it. And we'll be circulating the recording of all of this in multiples of our networks. So I encourage all of our audience and all of our people in the network to watch this, listen to this. Great key takeaways for me. For that, Dr. Hoedebecke, thank you so much for your time, especially on a Saturday. It's been a privilege to have you on our platform.
The privilege was mine, my friend. Thank you so much. I'll be happy to come back anytime.
Thank you. Raj?
Thank you. Thank you, Dr. Kyle Hoedebecke. In fact, if you're going to watch the replay, I request you to please comment, leave your questions also. And next week on Monday, 1st of Feb, we will continue to help you by nailing down the details that will give you an overview of how is healthcare evolution changing everyone's role. How can you emerge as a leader in healthcare by Dr. Clayton Ramsey. Make sure you stay tuned for the same. Thank you so much for everybody who had watched this live. And you can still send in your questions, or in case if you'd like to get featured on the podcast, inboxes on our social media handles. And this podcast is sponsored by DirectShift's clients and partners and clinicians. So if you want to ask a question in the future episode, make sure you stay tuned as well. So click on the comment section below, and we will stay tuned for watching more stories of this sort in the future. So sign up and experience as an employer, as a job seeker at directshifts.com. This is your host, Raj Misa, and thank you so much, Vamshi, and thank you, Dr. Kyle Hoedebecke, and we'll see you soon again. Thank you.
Thank you.